Welcome everyone to today's webinar. So my name's Kate. I'm the Community Engagement and Events Coordinator here at IHMRI. And of course, due to COVID, here's Mori. Welcome, Mori. So due to COVID-19, like most organisations, our events have all gone online. So we're delighted to be offer these monthly webinars. So today we'll be speaking with Dr. Kara Vine-Perrow, a senior researcher here at IHMRI, clinical professor Mori Aghmesheh, a medical oncologist at ISLHD, Ashley Hope, an IHMRI honours student, and Dr. Kimberly Davis, a breast cancer survivor. Thank you so much to all of you for taking the time to be a part of this webinar today. So to all those who are joining us, know that this is an interactive webinar. We want to hear from you. We want to have your questions. So please, as questions arise, just pop them in the Q&A box, which you'll find down at the bottom of your screen. And if you have any personal experience or anything you want to share, then please feel free to use the chat, the Zoom webinar chat on your right-hand side of your screen. For those of you who don't know, IHMRI stands for the Illawarra Health and Medical Research Institute, and we're a not-for-profit organisation. Our main goal is to support health and medical researchers in the Illawarra Shoalhaven region. Our goal is to bring scientists, researchers and doctors and health professionals together to help solve some of our greatest health challenges that affect our region. We do research into many different types of diseases, cancer, diabetes, mental illness and dementia, just to name a few. So today we're talking about the future of breast cancer treatment. And to start us off, I'd like to introduce Dr. Kimberly Davis. Kimberly obtained her PhD in 2015 from UOW for her work investigating tumour cell immortality. And in December 2016, Kimberly was diagnosed with triple positive stage 3 breast cancer. She understands the importance of new therapeutic developments, including how existing treatments have benefited her own treatment and her own health outcomes. So welcome, Kimberly.
Thanks, Kate.
So to begin with, can you just tell us a little bit about yourself?
Yeah, absolutely. So I studied at UOW. I did an undergraduate chemistry degree, did a PhD straight after in biochemistry. And then I'd finished that for about 2 years when I was diagnosed with breast cancer at 30. That was at the end of 2016. Since then, I've done a whole lot of other stuff, and I'm going really well. Everything's well. My health is good. So yeah, it was definitely a journey I didn't expect, but something that I've also been really passionate about in supporting both breast cancer research as well as encouraging young women to get tested.
Yeah. And so, can you tell us a little bit about your diagnosis? How? Can you just tell us what happened?
Yeah, for sure. So December 2016, I was diagnosed. I didn't find a lump, and I think people think, oh, it's a lump, it's like a pea or maybe a golf ball if it's really big. It wasn't. It felt like a hard ridge in the side of the breast. Didn't go to the doctor straight away because I thought, oh, it's not really a lump, right? Maybe it's something hormonal. And I was too young, I thought. Eventually, I did find some lumps in the armpit. So that was the lymph node involvement. And thought, okay, this is serious. I have to go to the doctor. So I was diagnosed with stage 3 breast cancer. The tumour was about 2/3 of the breast in size, so it was quite large. So it meant that initially it was inoperable, so I had to have chemo first. So that was definitely an introduction into the whole journey. I had what they call dose dense for the first rounds of chemotherapy, meaning that I had the treatment every 2 weeks instead of the regular 3. So that was 2 particular type of drugs, and they're ones that have been around for quite a while. It's known as AC. I then moved on to some more specific types of treatment, and that's because of the different subtypes of breast cancer, which everyone will hear about today. So I had a series of 3 drugs over the next little while. One of them was called Taxol. I had that for 12 weeks. each week. And then I started another drug called Herceptin because my tumour was HER2 positive, this HER2 growth protein. And I had that every 3 weeks for a whole year. And that's one of the newer line drugs, which was really interesting to be able to have. Thankfully, it's now funded on the PBS, but it costs about $50,000. I looked it up. It's pretty expensive, and thankfully the government now subsidises that. I also had another newer drug called Perjeta, which we did need to pay for. It wasn't $50,000, but again, I was really lucky to be able to have that. And it was only a few years ago that if people wanted to have Herceptin, they had to pay for it. And I'd heard that from some people, so I was really lucky to have that. After finished chemo, so that was about 5 months in all, I had a short break and then I had surgery, so full mastectomy, all my lymph nodes out. And then after maybe about 6 weeks or so, I had radiation, so 25 radiation sessions each workday, or each weekday, I should say. And then after that, I started tamoxifen, which is a hormone suppressor. So one of the other things my tumour was positive for was estrogen. So now I'm on 10 years worth of estrogen suppressing medication. It was pretty brutal, and there's still some side effects from the tamoxifen, but you know, I'm going well. When I had surgery, they did pathology on the removed tissue and there was no sign of the cancer, which was amazing.
Right.
My hair's grown back. I'm working now, and I'm working in a medical research field, and it's been really interesting to have both the patient experience as well as see the clinical side and understand how that works as well. Yeah, it was a big journey, but I'm grateful to be here and I'm going well.
We're grateful to have you here, and I'm so pleased that things worked out. Can you tell me, Kimberly, from the treatment that you had, what did you find the most challenging? Was it getting to your appointments? Was it the physical effects of the treatment? What did you find most challenging?
Look, for me, I think some of the physical effects, I was lucky to have some great support in my family. So getting to appointments was fine. I had both family and a couple of friends who would drive me places. I think everyone's experience is different depending on their circumstances. So for some people, getting to appointments is a really big deal and they find that really distressing. There's something that we call scanxiety, which is when you have to have your annual scans, you get really anxious about it. So for some people, going into appointments is really triggering, going into any clinical setting. I'm okay with that now, although the scans do cause a bit of anxiety, but definitely the treatment was really hard. And because I was young and healthy, my oncologist said, well, I'm going to hit you with the maximum dose that we can, because my body could take it. So again, that's something, and I'm sure Mori can talk more about that, something that the oncologists have to work out, how much can someone's body take of those different treatments.
Yeah.
So that was definitely brutal.
Yeah, and is that a little bit trial and error sometimes? Or
so mine was fairly straightforward. We didn't have to change the dose. I have known other women whose bodies haven't coped as well as mine did, and their oncologists have had to lower the dose. Everyone has so much individual stories. So for instance, Herceptin can cause some heart problems because that protein is also found on your heart. So I had a heart scan every 3 months. I was fine, but I have known a couple of other ladies who've had to stop their treatment for a little while because their heart function decreased. I was lucky, others aren't. So it's very individual.
Oh, look, and I think that's something that we hear all the time. Is everybody's journey is a little bit different. The treatment they receive is different, and yeah, but thank you so much, Kimberly, for sharing your story. It's a very generous thing to do, and we're really grateful to have you here today.
You're welcome.
So at IHMRI, we're really passionate and really grateful to have the researchers that we have on board. Dr. Kara Vine-Perrow dedicates her time to looking at better treatments for cancer. And Kara, if you're happy to, could you just give us a little bit of an overview of the type of work that your team does at IHMRI?
Sure. So I guess in a nutshell, what my lab tries to do is design better drugs or better ways to deliver drugs. So we heard about Kimberly's story. It was, the treatments that were a real challenge for her. And so in my lab, we design customizable drug delivery systems So this enables targeted drug delivery to the specific cell types that we're after in the body in order to increase that therapeutic response and reduce the toxicity profiles. So, we've heard about, Kimberly's story, and we know that in the context of breast and other cancers that conventional chemotherapeutic treatment often requires high drug doses, repeated drug doses that are toxic to the patient. And, this can result in those severe side effects that Kimberly was talking about before. But it also can lead to resistance to therapy as well. And that's a huge problem. So initially the patient might respond to treatment, and then over the course of the treatment period, they may not. And so, this is a challenge that we're trying to solve, I guess, as well. And so we're doing this in a number of different ways. And so one example is a project where we're looking to load nanoparticles. So these are small microscopic particles that are 100,000 times smaller than the diameter of a human hair.
Wow.
With cytotoxic drugs, so the same ones that Kimberly was talking about, package them into these tiny particles. And then we engineer the surface of these particles with proteins or antibodies, so like little GPS tracking devices that can selectively seek out and destroy those breast cancer cells that we're trying to target. And ultimately, these nanoparticles bind to the surface of the cells in a lock and key style manner. The entire nanoparticle is taken up, and then the toxic drug is delivered to that specific cell type. And, in this way, we can deliver high concentrations of drugs to those cancer cells and try and reduce the off-target toxicity. So that's one project. And then another project that we're working on is looking at using implantable drug delivery systems. So essentially what we're using is biodegradable and biocompatible polymers that we can load these combinations of toxic drugs into, and we can directly deliver these implantable devices where they're needed in the body, so adjacent to or within the tumour. And again, this gets around the issue of whole body toxicity that we see if we give the chemotherapeutic via the bloodstream. And our group has previously prepared these implants, and we've shown them to work really nicely in some of our preclinical lab models in the context of pancreatic cancer. And we're now looking to apply this technology to harder to treat breast cancers. And that's something that Ashley Hope has been working on in my lab as an honours student over the past year. So I thought I would let Ashley talk to you a little bit more about that particular technology.
Thanks, Kara. I was really lucky to complete an honours project with Kara this year, focusing on the development of the biodegradable implant in the context of triple-negative breast cancer. So triple-negative breast cancer is a particular subtype of breast cancer. It represents up to 20% of all breast cancer cases, and it's generally a lot tougher to treat than other subtypes of breast cancer. And this is because triple-negative breast cancer lacks hormone receptors, so estrogen and progesterone receptors, and it also lacks HER2 receptors. So this means that we can't target this particular subtype of breast cancer with targeted drugs that target these receptors, and thus chemotherapy is the mainstay of treatment. And as you may have heard Kimberly mention and Kara mention, chemo requires a high dose of drug to be delivered for it to be effective most of the time. And often this is quite toxic to the patient. So as most people know, chemo has a lot of toxic side effects, from nausea to heart failure. These can be really serious and require the patient to have their dose lowered or stop the treatment entirely. So the focus of my research this year was to load our implant with chemo drugs that are already used and are conventional for the treatment of triple-negative breast cancer, alongside newer treatments like immunotherapies. And the implant will be designed to be implanted directly into the tumour to deliver a high concentration of drug directly where it is needed, so that there are less toxic side effects for the patient And also, cancer, especially solid tumours like breast cancer, can be actually quite clever, and they can recruit normal cells surrounding the tumour to develop a very dense tissue called stroma, and this makes it really hard for the drug, when it's delivered intravenously, to actually get to where it's needed in the tumour. So by implanting a device directly into the tumour, you're able to circumvent these issues, so that you get a high dose of the drug where it's needed.
Great, thanks so much for sharing that with us, Ashley. Can I, if you don't mind, can I just ask, how did you choose, why did you choose to go in this direction in terms of triple negative breast cancer over other cancers or other diseases?
I think when I was growing up, I actually had a few friends and their mums be diagnosed with breast cancer. So I was exposed to what an issue breast cancer was at a very early age. But there's actually not a lot. I think I only heard the term triple negative breast cancer probably last year when I was looking at potential honours projects to go with. And I actually didn't know that there were different types of breast cancer. And I think triple negative breast cancer in particular has been left behind in a lot of ways regarding research with new therapies, simply because we didn't know a lot about triple negative breast cancer up until the last 20 years, when it was, I think, recent research has shown that it's actually a very diverse subtype of breast cancer within itself. And we've only recently sort of appreciated the importance of the immune system in this particular subtype of breast cancer, meaning that immunotherapy has become a really exciting and up-and-coming area of research for this area of breast cancer. And I've always been really interested in the immune system growing up and along my degree, so I thought it would be really cool to sort of, amalgamate my two areas of interest together and target breast cancer with our immune system.
Fantastic. Thanks, Ashley. I know we'll come back to the work that you're the research that you're working on a little bit later, but since you mentioned immunotherapy treatment, I thought we might just jump over to Mori, introduce Mori. Can you hear us okay?
Yes,
yeah.
I can hear you.
No, this is an area that you're that a lot of your research focuses on. Can you tell us a little bit more about immunotherapy treatment and what that looks like?
So I guess you can hear me okay?
Yes.
Yep. So I guess the all of the conventional treatment that has been utilized in the last few decades, the main idea has been to target the cancers. So, for example, the conventional chemotherapy is essentially targeting any cells in the body that grow fast. So we know that the cancer cells, specifically the aggressive type of the cancer cells, they do grow very fast, and that's where the chemotherapy target them. But unfortunately, they target some of the other normal cells that they grow relatively fast, like the lining of all the gastrointestinal system. That's where all those nausea, vomiting, diarrhea side effects come from, or the hair follicles that they grow fast, that then they get targeted by chemotherapy, as a sort of side effect, which then goes hair loss, and there's few others of these sort of complications. Now, moving forward, we're looking at more targeted drugs, like, as I think Kimberly was talking about, using the Herceptin, using the Perjeta, or even using some of these hormone therapy, like against the estrogen receptor or progesterone receptors, all those tamoxifens. These are, in a way, more targeted, because you try to target the specific receptors and surface of the cancer cells, that you try to target those cells rather than other normal cells. Despite that, you do target some of the other normal cells, because these cells are potentially having some similar receptors. But this is generally, conventional treatment has been trying to target the cancer cells and try to kill them. Whereas the immunotherapy is a slightly different concept. So if we move one step back again, the cancer cells develops for quite a few different reasons. One of the main reasons is that they can actually somehow escape from the immune system. Because if immune system recognize cancer cells, which generally should be something abnormal in these cells, that they grow fast, then the immune system can get rid of them. Now, there's two pathways. Either there is some smart mechanisms that the cancer cells develop to be able to escape from the immune system in a way to go under the radar of the immune system, or there might be some deficiencies in our immune system that cannot recognize these cells as abnormal. So the immunotherapy started to try to overcome this problem and try to see whether we can reintroduce these cancer cells as abnormal cells to the immune system. If that happened, then the immune system recognized them and target them. And that's the best sort of treatment. If the immune system recognize them, they can easily get rid of them. And the other advantage is it can go to memory of the immune system. Then at any point they restart to grow, they can get targeted again. So I think that's the ideal scenario, that if the immune system recognizes them, then we can say potentially this patient can be cured, and potentially this cancer may never come back because the immune system will recognize them in the future as well. So that's where the immune system comes to the equation for the treatment of the cancer, and has been, obviously the research has been going for many decades. I think, in fact, in 1960s and 70s, the first time they tried with some success, but not knowing exactly how it works. I think the new sort of explosion of the immunotherapy happened only during the last few years because of the better understanding of the interaction between the cancer cells and immune cells. And one of the major ones has been this sort of, wrong friendship relation between the cancer cells and the immune system. We found that, there has been an interaction between our immune cells and the cancer cells, that relation cause the cancer cells can actually grow and, in a way, shake a friendship hands with the immune system. So the most of the new immunotherapies try to break down that wrong friendship by blocking those interactions. So I think the most successful stories is in melanoma, and that's the first immunotherapy drugs that successfully showed significant improvement in the outcome of the cancer was melanoma. And that's obviously standard of care. These days, we do not use chemotherapy in treatment of melanoma. In fact, the last time that I have used the chemotherapy, I think it must have been 2011 or 2012, that I used chemotherapy for melanoma. So last probably at least 5 years, I have not used any chemotherapy for melanoma patient. Obviously, melanoma is the lead in this area, and other cancers has been followed. For example, immunotherapy now is indicated in lung cancer, in kidney cancers, in bladder cancer, in some of the skin cancers, and there has been sort of a slowly growing in other tumor groups. Now, this has not happened in breast cancer as yet. Now, some of the other cancers, these sort of treatment that has become standard has been tested, but has been shown no significant impact. The breast cancer, the triple negative breast cancer has been the only subgroup of the breast cancer which has shown some positive signals in response to the immunotherapy. And there's a couple of studies that has been positive in this field, resulted in some provision of some access program by a company for triple negative breast cancer, but it still is not on Medicare or PPS. I'm not sure if I probably went too long a story about this.
That was great, Mori. Thank you. So there's hope for the future for other types of cancers, but not quite yet. But that's great news that it's working for melanoma, and yeah. And so in terms of, I know all cancers are different, and they present differently in different people. I wonder, Kara, might you be able to tell us a little bit about why different breast cancers specifically require different treatment approaches?
Yeah, so you're right, Kate, that you know, all cancers are different, and I guess that's true in the context of breast cancer as well. It's not just one disease, so there are different types and there are different subtypes that are collectively referred to as breast cancer. And breast cancers, like many other cancers, can vary genetically and biologically from one another. And so it makes sense that if we identify the difference between them, then we can treat them in a specialised way. So, you know, we've previously heard from Kimberly and Ashley, you know, that breast cancers can be categorised based on their hormone receptor status, for example, or the expression of the protein HER2 on the surface, or none of those at all. And so we know, for example, if a breast cancer is ER positive, that it's the growth and division of those cells are driven by the hormone estrogen. And therefore, we can come in and use endocrine therapy, such as tamoxifen, or we can use aromatase inhibitors, for example, to treat that particular subtype of cancer. We know that it will respond, and there's a positive outcome for the patient. And so, you know, in the context of ER negative cancer, there's no use using that treatment. So what we're doing is we're finding out a lot more about the genetics of these different subtypes of cancer, and that allows us a more personalised or tailored treatment approach versus a one-size-fits-all treatment approach.
So just to clarify, and forgive me, I hope this isn't a silly question, but you mentioned the ER positive cancer types. That means that they're receptive to estrogen. So in terms of the treatment, does that mean then that you would lower the estrogen that's within the woman's body so that the tumours can't grow? Is that right?
Yeah, that's correct. So you essentially use an inhibitor of that pathway. So you're cutting off the supply of the signal to that cancer cell that tells it to continue growing. And through that inhibition, you essentially can control the tumour that way.
Okay, thanks, Kara.
Kate, sorry, you're on mute.
Thanks, Kara. Sorry for that. Mori, I was just going to jump back to you, if that's okay. We've been hearing about different subtypes of breast cancers that are particularly difficult to treat. How common are these types of breast cancers? And what makes them harder to treat?
So if you are particularly talking about the triple negative breast cancer, that's approximately 15% of the breast cancers are triple negative. Triple positive or HER2 positive group is around 20 to 25% of the breast cancer. Well, different studies reported probably could be related to population as well, but it can be ranged from 15% to 25% in case of HER2 positive. But the triple negatives are roughly around 15%. And as it was mentioned, I think, by Ashley and probably to some extent by Kara, that this is because we don't have a good target. It doesn't mean that, I mean, it's interesting if you look at the history of the HER2 positive breast cancer, because the Herceptin, as Kimberly was mentioned, I think around 2006, 2007 came to the PBS in Australia. Prior to that, the HER2 positive breast cancer was a lot worse disease because it was more aggressive, a lot more common to have the brain metastases from the HER2 positive breast cancers. Now, this has been significantly changed to the extent that the HER2 positive is actually doing better than the HER2 negative because of the good drugs that we have targeting the HER2. And, again, as Kimberly was saying, that, having Herceptin and Perjeta available in the early stage breast cancer, it helps actually to change the outcome from being, worse to better than the HER2 negative disease. I believe, we could do the same things with the triple negative, because the triple negative means that those three receptors that we know is not existing, but it must have been other targets that we cannot identify at this stage. I think I guess one advantage of the triple negative now would be that potentially you might be more immunoresponsive than the triple positive breast cancer. So I guess, in a way, we have to just find the right target for any subtype of the tumor groups, including the breast cancer, to be able to treat these, tumors, more specifically, rather than giving a treatment that is it's broader spectrum for all tumor groups.
Thanks, Mori. That's great. Kara, back to you. I wonder, obviously there's clinicians and researchers the world over looking into the best way to treat cancers, and the interest of our webinar, different types of breast cancers. How often, or would you collaborate with clinicians from perhaps within Australia or worldwide? And how does that happen? How does that come about?
So I absolutely think that collaboration between fundamental medical research scientists and clinicians is important for driving our research forward, and in order to translate our findings from the bench to the bedside. Professor Aghmesheh and I have collaborated for the last 5 or 6 years, and I've collaborated with other oncologists and clinicians in the Illawarra Shoalhaven local health district as well. And I think it's really important because, clinicians and research scientists, fundamental or basic research scientists, think about things in different ways. And when you get people who see things from different perspectives coming together, you often get, a more holistic or global viewpoint of the situation or the problem. And so, in the case of Mori and I collaborating, Mori came to us with a clinical problem, and by understanding the tools and the technologies that we had available here in IHMRI and at University of Wollongong, we were able to set out and start to try and tackle that problem. And I absolutely think if research is to be translated, then, that relationship between clinicians and researchers is absolutely key.
Thanks, Kara. And so through, Kara, just going back to the drugs and clinical practice, how long does it take then to get a drug from that research stage into clinical practice?
So this is a question I get asked quite a lot, and unfortunately the answer is not great. So on average, it takes about 15 years to get a drug from the lab into the clinic or the marketplace, give or take. And this is because the process of approval is really tightly controlled by government regulatory agencies. So, for example, in the US, it's the Food and Drug Administration, and in Australia, it's the Therapeutics Good Administration. And each of these agencies require a certain number of steps to be performed and ticked off before that drug can be approved for use. And if you think about it, it's really to ensure that the drug that's being developed will benefit the patient for that particular disease in which they're developing the drug for. And so just briefly, I thought I'd run everybody through, the sequence of events that have to happen before a drug is approved. And so you usually start with the preclinical drug testing phase. And this usually happens in, a research institute, a university, or a small pharmaceutical company, in which we use non-human disease models to study the effect of the drug on the disease and to test whether or not the drug is actually safe. And this usually takes between 4 and 5 years, depending on resources, funding, and other infrastructure. And then we move on to filing what we call an investigational new drug application. And this is an application to the regulatory body, such as the FDA or TGA, and it summarises all of the information that we found during that preclinical study, how the drug works, how long it's in the body for, what its mechanism of action is it safe, and how the drug is manufactured. Once that's approved, we're allowed to then move into humans, and that starts at a phase 1 clinical trial. And that's usually in a very small number of patients, anywhere between 20 to 80 patients. And essentially this works out a safe dose that we can use. So what dose is tolerated in this patient? And then what does the body do to the drug? How is it absorbed, distributed, metabolized, excreted? And that takes on average 1 to 2 years. And then we can move on to the phase 2 trial, which usually involves around 50 to 100 people who have the target illness. So the illness that we're trying to cure or treat. and it gives information to us about how well the drug works, how efficacious it is, and more information about the dose. And this might take 2 or 3 years. And then still, if the medicine looks promising after these early trials, then we move on to bigger phase 3 trials. And these are large randomized trials that are usually involve around 1,000 to 3,000 people with the target illness. And then information from this trial, if positive, will then go to the regulatory body, and a new drug application will be filed following that trial. And, you know, altogether that process may take another 4 or 5 years. And so, you know, along the way, there's a number of factors that can affect the speed of those approval processes, including funding, target populations. You know, if you're looking at a rarer disease and you need to recruit a certain number of patients, well, you may be limited in the number of patients that are coming forward and you're recruiting. And so that might extend out your clinical trial. So there's a number of factors that are at play. It is a long and drawn out process, and I don't know whether I should mention this or not, but I guess it's the reality of it, that only 5 in 5,000 drugs that are tested in the preclinical setting progress to human testing, and then only one of these 5 drugs then are tested in only of the 5 drugs then that are tested in people, only one of those are approved for use. So that makes a 1 in 5,000 kind of, So I mean, but that shouldn't deter us from moving forward, and it certainly doesn't deter us.
And those statistics are as they are because of safety for the community. Is that right? It's safety. It is safety, but it also comes down to ensuring that we have accurate models of human disease. And so this is an area of research that I'm looking into, and others obviously around in Australia and globally are looking at how can we better model the human disease in an animal, you know, or take a patient sample and culture that, so that when we get a drug response profile, that actually is going to inform us of the same kind of response that we might observe, in the human. So there's lots of research being invested into that space to refine our laboratory models so that they better predict patient response. Yeah, right. And you mentioned funding. I'm sure no one is surprised to hear that funding is decreasing across the research space. What helps you as a researcher in terms of getting your research done?
Obviously, you know, I need talented, not just me, we all need talented young scientists, like Ashley, for example. These are the scientists who are in the lab doing the work, and the funding really ensures that we can keep those research scientists who we've invested time into training, and upskilling essentially. They're the ones that need to be around to do the work. And when we have gaps in funding, we have gaps in momentum of our research as well. It means we have to retrain or start from scratch again. And I guess, you know, I've been really lucky in the past to have received a lot of community support. So, for example, I received some funds that were raised in 2018 as part of the Glitz and Glamour Ball that Kimberly was a huge part of there. And we're extremely grateful for that. So that's allowed us to do a full year's worth of preclinical workup on our new therapy for triple-negative breast cancer. It's helped us employ, you know, those talented young scientists that I was talking about and build research capacity in breast cancer within the Illawarra. And so, yeah, we've been extremely lucky. The Illawarra Cancer Carers obviously have helped us out in the past before. They've donated money to us, allowed us to generate some pilot data that we then put into a larger grant application, and we applied for some money from the National Health and Medical Research Council. And part of a side scheme of that, we were funded. And so that then gave us, we were able to leverage that community support and gain an extra 3 years worth of funding to progress some other work that we're doing. So we've been extremely lucky there.
Fantastic, really great. It really shows how it's a real team effort that through consultation with the community, and then understanding what you're doing and wanting to support you actually enables a project that potentially would have stalled or stopped, had allowed it then to continue, which is really wonderful to hear. Yeah. So I think we might, thank you, Kara, and I think we might just go to some questions now. Thank you to all those who have sent them in. Sean wanted to know, and this may have been answered, but I wonder if somebody could just clarify. Sean wants to know, what are the 3 receptors that specify classification of negative or positive? Would anyone like to take that question?
Well, I think I can answer that. The positive and negative, I think at the moment, these are the 3, the estrogen receptor, progesterone receptor, and there's a HER2 receptors. So estrogen receptor and progesterone receptors are hormone receptors. As you know, the estrogen and progesterone are 2 common hormones. And the HER2 is a epidermal growth factor receptors, which is a slightly different type of the receptor. So presence or absence of these receptors classify them to be, either ER positive, PR positive, HER2 positive, or it could be all the combination of someone could be ER positive, PR negative, HER2 negative, or triple negative, means all of those 3 receptors are not existing in the surface of the cancer cells.
Great, thank you, Mori. Sean, I hope that's answered your question. So we've got an anonymous question here. This person would like to know, if there's evidence of breast pain, such as a stabbing pain, could this be a sign or a precursor of breast cancer? And this person would also like to thank everybody in the panel for participating in this webinar and allowing it to happen.
I'm happy to answer that as well. Look, generally, aches and pain, majority of the breast cancer, breast lumps, they're actually asymptomatic in regards to the pain. So mostly there's no pain associated with the breast cancer. Having said that, there are some minority that they might present with some aches and pain. So I think if there is, stabbing aches and pain, one thing is it's not alarming. It doesn't mean that this is, it's much less likely to be a cancer, but it doesn't 100% exclude that it's not cancer. So I think it always needs to be checked.
So your message, Mori, would be to go in the first instance to your GP? That's
exactly right, yeah. To be examined and investigate, yeah.
Okay. Paula, unfortunately, was diagnosed during pregnancy. She's interested to know more about how common this is and why some doctors prefer to treat to treat with chemo rather than surgery, and vice versa. I think that might be one for you as well, Mori.
Sure. Look, I mean, it's not very common to have the breast cancer during pregnancy. And in regards to the treatment, it depends on the type of the breast cancer, and it depends on the stage. It depends whether the lymph nodes are involved or not. If it's fairly straightforward, earlier stage, low grade, you may even be able to wait until the pregnancy finished and then you do the surgery. It depends on the subtype. But if it's high grade, or if there's high risk groups of the breast cancers, then they may decide to have some chemotherapy at the time. Now, it's interesting to know that chemotherapy, so far, there is no indication that there is a sinister outcome to the baby if you give the chemotherapy not in the first trimester, but in the second and third trimester. You can actually administer the chemotherapy fairly safely to the pregnant ladies. So I guess it comes back to the stage of the disease, the biological behavior of the cancers, the receptor status, to decide what's the best approach, to go upfront surgery or to have some chemotherapy or to wait until pregnancy finished and then have the treatment.
Okay, great. Thank you, Mori. Paula, hopefully that's answered your question as well. We've got a question here from Jody. Jody wants to know what clinical trials our researchers are currently involved in.
I think that's a good question, and I was hoping someone asked that, because I think that's a good thing to also mention, that I think, the clinical trials are really important part of the cancer treatment. As earlier you were discussing about the process of the drug from the lab to reach to the clinic, goes through a lot of different stages. And that's when it comes to the human trial, there's phase 1, phase 2, phase 3, and sometimes even there's phase 4. Now, with the clinical trials, we're trying to get as much as possible to Wollongong. And I have to say, the Wollongong, we're proud that the Wollongong was part of the clinical trial for the Herceptin largest international trials, and we recruited some patients in Wollongong. So it indicates that there are some of these drugs that might not be available at the time, but we may be able to offer these new treatments, earlier than what is available. So, in the trials that mostly we do in here, we do run all the phase 1, 2, and 3, but we do have some trials that you can get access online. There is different ways that you could look for the trial. One of the best probably is the Clin Trial Refer, that you could actually, for the New South Wales, there is a Clin Trial Refer which lists all the available trials in New South Wales, including it at Wollongong. The trials that we are running in here will be accessible through that website. But also, our trial coordinators, we would have breast clinical trial nurse that they can always reach to them and ask what trials we have. But I just very quickly mentioned that we do have quite a few trials at the moment for the breast cancer. For example, at Wollongong Hospital, we're on one trial which is called the Expert Trial, which it's looking at to see if we can omit the radiation in some of the patients who have got extremely low risk of the breast cancer, and which is currently standard of care to give the radiation after the surgery. And also we have a BRCAP trial, which is in fact, this is in the really patients who have underlying genetic predisposing factors to develop breast cancer, but they have no cancers, that there are some treatment intervention that can be offered for 2 years to prevent further the risk of developing breast cancer in those individuals that they have no cancers. We also have some trials which is the some of the newer hormonal therapy, which we add to the standard hormonal therapy. This is in the advanced setting of the breast cancer. We just finished a trial which was called Palace Trial, which was an international trial, which was trying to add another drug to standard of care hormone treatment after having the surgery for estrogen receptor positive breast cancers. And we also had another trials which was also for hormone positive breast cancer. So there's quite a few trials that I, because of the time, I can't go through them.
Yeah.
But it's always good to reach to the nurse coordinators, and you can reach to the cancer centres. They will be able to answer those questions.
That's great to hear that there's so much going on in the way of clinical trials, Mori. And I think what I'll do, if you have any information that you might be able to send to me, or I can do some research and send that through to everybody who's dialed in today, just to give you some information about how to join a clinical trial, or where to go to get more information on the clinical trials that are taking place in and around that area. So thanks so much, Mori. I've got a question here. Somebody is starting tamoxifen soon, and she's anxious about the possible side effects. She's 30 years old and worried about the effects on menopausal-like symptoms and sexual function. And somebody else has mentioned about tamoxifen and wondered whether Kimberly might have any tips on how to manage any side effects. Is that something that you'd be comfortable answering, Kimberly?
Yeah, no, that's fine. Yeah, tamoxifen is an interesting one, and I'm sure Mori will have something that he can add to from a clinical perspective, but what I've definitely noticed is that people experience side effects really differently. So what one person has, another person may not have. So to those who have asked and are either have started or about to start, I would say don't freak out too much about things you may have heard from other women. don't freak out about what you read on the internet because they'll tell you you're going to have all the symptoms. For me, I've had some bad hot flushes, and fatigue has been particularly problematic. Remember as well, there are other ways to get around it. So it's a balance for your oncologist to work out being on tamoxifen and how that is definitely really, really important for your future health, but also quality of life. So what I ended up doing with my oncologist was I was able to take some other drugs that I wasn't taking them for the purposes of hot flushes, but they have a nice little side effect, which is actually helping with hot flushes. So I'm now on 2 different medications for that. And I did actually have a little bit of a break for a while. My body was really struggling. Went off tamoxifen for a couple of months, went on to a half dose. I'm now back on a full dose. So I am noticing the fatigue more, but it definitely helped my body adjust. So what I'd say is don't freak out, but please do talk to your oncologist. Keep a record of what's going on, maybe date things, and your oncologist
diary.
Yeah, absolutely.
And
yeah, and your oncologist can help you with that. And there are things around it. So they're the ones that happen for me. And sometimes it is really, really frustrating. But there are ways to get around it. And, you know, it's one of the awful things. And hopefully one of these targeted treatments one day will be even better and we won't have side effects. You're on mute, Kate.
Thank you. Thanks so much for that, Kimberly. Mori, was there anything, did you want to add anything to that?
Oh, I guess the only thing I was going to say, you know, one thing that unfortunately it can be scary because what we do is normally when we are planning to start any treatment, including the tamoxifen, we usually give a printout which has got a list of all potential side effects. And sometimes that could be, when you look up the list of side effects, it could be scary. And but I have to say, you know, I say to some of my patients, have a look at the Panadol side effects list, which can kill the person as well. But, you know, one advice is, you know, some patients, they actually take the tamoxifen and they feel no difference. Some, they get really significant side effects. You have no choice than to stop that. But there is a whole range. As Kimberly was saying, some people may have only mild reaction, and it depends on what sort of side effects you get. Then you could always, the oncologist can try to adjust the dose, or, you know, try to add other drugs, or there's sometimes very simple instruction can help with some of these side effects. One place to look up is the Cancer Council website, which has got very, New South Wales Cancer Council, which has got really some of the practical aspects, and you know, even about the exercise, about the diet, and also, you know, how to manage some of the side effects.
Great, thanks very much, Mori. It's a great tip. So I'm just aware of the time. We've only got about 5 minutes left, and I do apologise in advance for any questions that we aren't able to get to, but I will pose the questions that we aren't able to answer to our panellists after the webinar, and I will get back to you with an answer to those. But I wondered whether this might be something that Ashley might be able to talk us through. Lucy wants to know whether there have been any immunotherapy drugs trialed for triple negative breast cancer. Is that something that you're happy to answer? Or
yeah, more than happy to. So to the best of my knowledge, there is currently only one FDA approved immunotherapy drug for metastatic triple negative breast cancer, so when it's spread, and that one is called atezolizumab. So this particular immunotherapy drug targets an immune checkpoint on the breast cancer cell. So what immune checkpoints do is they're naturally found in our body, and our immune cells like to use immune checkpoints so that we don't, so it doesn't go too crazy, and it prevents autoimmunity. But what cancer can do is it can overexpress this immune checkpoint and form, like Mori was saying, a handshake between your immune cells and breast cancer cells. So your immune cells don't recognize the cancer as an enemy of the body. So by inhibiting this handshake, your immune cells can then go and attack the tumor again. So the atezolizumab one has been approved, and there's also, I think there's hundreds of clinical trials currently under development at the moment. Most of them are either atezolizumab or similar to atezolizumab, and they're often used in combination with chemotherapy. And this gives like a sort of additive or synergistic effect to treat the cancer. But there are also some newer drugs under preclinical development, and we are currently about to do an animal study using one of these, and these are called immune primers, and when used in combination with immune checkpoint inhibitors, they give an even more robust immune response against the cancer. So yeah, to summarize, I guess there's hundreds of clinical trials undergoing at the moment, and hopefully more approvals will be seen soon.
Fantastic, thank you, Ashley. So there's lots going on in the immunotherapy space by the sounds of it. Christy wants to know, can you trial immunotherapy if you are currently an NED, or do you have to have a tumour at the time? Does that make sense? Sorry, I'm not familiar with the term NED. Ned, does anybody?
I'm not sure what it means.
Oh, okay. Well, Christy, if you'd like to just, oh, sorry.
I think it means no evidence of disease.
Exactly.
Oh, okay.
Kimberly. Thanks for that. Thanks for clarification, Christy. Kimberly. Mori, is that for you?
Yeah, I can answer that. Look, I mean, I can very briefly mention these few pivotal trial that if people wants to have a look, I just briefly mentioned the name. There's a Impassion 130. They're coming with very bizarre names of the trials, which you can Google it and you can find. Impassion 130 is a trial that was successfully showed the benefit of the immunotherapy in the advanced triple-negative breast cancer. And then there is Impassion 030, and that's in the earlier stage breast cancer. And that's exactly what Ashley was saying. That's the atezolizumab. It's a drug that is from the Roche company. But there are also some trials from the MSD that also they have tried that in the advanced setting. So based on those sort of pivotal trials, what is currently available is the first thing is in the setting of the advanced triple-negative breast cancer, the Roche provided some access program to atezolizumab. That's in the advanced triple-negative breast cancer on the first-line treatment. So unfortunately, it's not available on the second or third line in the advanced setting. There's no drug currently available in the earlier stage breast cancer in view of either on the Medicare or any access program unless the patient wants to pay, which I do not recommend because we're still experimenting this in the earlier stage. So, but as Ashley mentioned and you mentioned as well, there's a lot of trials in New South Wales. We don't have anything in Wollongong in triple-negative breast cancer at the moment in case of the immunotherapy trial, but there are some running at Sydney that you could always look up, and you know, I'm happy to send you, Kate, the potential links that they can look up for the trials.
That would be really helpful, Mori. Thank you. And then I can send that on to everyone, along with a copy of the recording of the webinar. So we're just about run out of time. Does anybody have any last minute thing that they would like to add to just round up the webinar around the future of the treatment of breast cancer?
Kate, sorry.
No, you go, Mori.
I just sent a 2-page slides. I'm not sure if I can share that. Maybe if Kara, you want to go ahead and mention it, I'm happy to leave that out.
Look, I didn't necessarily want to talk about the future of research other than to say that, you know, has been a huge investment of funding into this area because we know how much of a problem this is for men and women. And you know that we're working extremely hard and tackling the problems in new and different ways. But I did also want to say that our research group really benefits from our interactions with community. I love talking to patient advocates, cancer survivors, people who just generally want to know more. And we always have our lab doors open here at IHMRI. So if anyone's interested in learning more about some of the research that Ashley, Mori and I are doing, or other projects, then please get in touch. We'd love to have you here. We'd love you to come in and sit in on some of our meetings if you like, and get to know you a little bit more. So I just wanted to finish with that. Thanks.
Thanks, Kara. And when restrictions do begin to ease and we can begin to comfortably invite people into IHMRI, that's absolutely something that we'd like to look at doing. We've got some irons in the fire for next year, so keep an eye on this space. Look, we have run out of time now, so I just want to thank all of my panelists for your time today. Really, really appreciate all your hard work and dedication to research and the clinical aspect of treating breast cancer. Thank you so much for joining us today, and thank you to everyone who's dialed in. We've got, just so the panelists know, there's lots of comments coming through from our audience saying thank you so much for your time. So just to conclude, if you haven't already, register for IHMRI's newsletters. I put them together and I send them out once a month, and that will include information on clinical trials and also any events that we will be holding. So please register for that. I'll put a slide up at the end of the webinar so that you can all see that. But head to www.ihmri.org.au for information on that. We also will have a little survey at the end of the webinar. If you do have 2 minutes to fill that in, we would really appreciate it. We hold these webinars for you, so we want to make sure that we're giving you information and content that you want to see. So thank you again to all of my panelists and to all of our guests. We really do appreciate your support, and thank you for dialing in. See you next time.
Thank you.
Thank you, everyone.